Dr. Amer is a consultant pediatric gastroenterology in SKMC. He's already associate professor in Khalifa University, Abu Dhabi. And also he's specialized in the fecal microbiota transplantation. This is something very unique. And I think we need to know from Dr. Amer what this one, because maybe we don't have this background for this one. Also, he's having a senior lecturer for the year in UK. And already he's having a lot of research in Hull University, UK as well. Welcome, Dr. Ram. And this is for you, please.
Okay. Thank you very much. Can we have the slides on, please? Well, I would like to extend my thanks really to Mohammed and to the organizing team for giving me the chance to speak to you here. And I think I feel privileged being among you guys. You know, I think most of you here are just immunologists, pulmonologists, and perhaps some of the dermatology people. I'm not sure if there is any pediatricians about Ahmed here, or any with particular experience in gastroenterology. So out of what I was going to speak about, I thought I may just give you a sort of an overview of such eosinophilic disorders on the gastrointestinal side from the clinical point of view. I think really I just wanted to give you an idea about what goes on the other side of the table. You may actually see the patient referred to you, with the diagnosis being established or thought about, and we seek your help as immunologists and allergists in sort of trying to further manage the case. So I'd like to give you an idea about what goes on before that. So to really understand what actually happened and what to expect in such patients. And in doing so, I may just draw the comparison between the adults and the pediatrics. I believe most of you are experienced or dealing more with adults rather than children. So I might just try and draw the comparison between the two different groups. And because of the nature of what has been going on and the evidence available, I think we'll focus more on the eosinophilic esophagitis in comparison to the other varieties. And we'll put a flavor of reality in it. So we'll discuss part of a real case there. In doing so, I may sort of raise some questions about the uncertainties and what is thought to be right and what is thought to be wrong. And perhaps, we'll talk about, or we'll touch about, features of what is coming on and what has already been discussed. So I think, more than me, really, that there has been really an increased incidence of such cases over time. And in particular, say, in reference to the eosinophilic esophagitis here, it's fairly a recent condition. It's basically just over the last 20, 25 years that it has been recognized and identified as a particular case. And as you can see here, clearly, sort of just started to be identified. There hardly any actual reported incidents, to the tremendous rise really over 20 years. That is data from Netherlands, really an elegant study done looking at the register of diagnosed histologically confirmed cases of eosinophilic esophagitis. And what they found, as you can see, the incidence has risen quite highly to almost here, comparing females to females and comparing children to adults. If you can see the risk here, it's almost maximum at 4.6 cases per 100,000, right? And that is sort of here merely comparing females to males. As you can see, the incidence tops at about 35 years, between 30 to 50 years. Kids come at around 16%, and also less at the higher end of the other side. A similar pattern here, sort of a consistent pattern. As you can see, the differentiation between males and females is basically constant. About 70% of the new cases are actually males. Males are dominating such a condition. Now, despite the reference to allergies and to inhaled allergies in particular, the reported seasonal variation is not there. Whether there has been a delay in picking up the diagnosis or delay in actually confirming them, but there has been no actual difference in the seasonal incidence. Now, the most important fact here, as I can see it really, you may well see, well, we are actually diagnosing more because we have become more aware of it. We are able to do more endoscopies and things like this. But cleverly, they looked at the number of endoscopies with histology. It has remained almost the same over the same period. These people actually looked at pathology registry, confirmed cases of eosinophilic esophagitis. So the number of endoscopies hasn't actually increased by 100,000 individuals, yet the actual cases kept on rising. So there must be something that resulted in such rise of such a condition. There must be something, promoting the development of such a case. There might be a real increase in the incidence, not just being able to diagnose more. So because of this, I think it is important for us to know about such a condition. It's increasing, it's there, it's fairly common. We cannot really ignore it, so better to be aware of it. So what is it we're actually dealing with? By definition, it's actually, yes, like the asthma, like the eczema, it's chronic inflammation of the GI tract. Now, characterized by what? Sort of basically, yes, there is histology manifested by dense eosinophilic infiltration in whatever segment of the gut. That infiltration results in clinically detectable symptoms and signs of dysfunction of that part of the gut, whether it is the esophagus, the stomach, or the intestines and beyond. But I think the difference here, I was listening to various speakers yesterday in relation to eosinophilic asthma, in relation to eosinophilic dermatitis, no mention to the fact that, yes, you see eosinophils there, but you have to exclude other secondary causes. This is the must here. You diagnose it, there is eosinophils there, you cannot label it as eosinophilic gastroenteropathy unless you rule out other possible causes. So these are the list of other possible causes. I think, people are, one way or another, they're actually excluding it, of course, like the case discussed yesterday, trying to exclude drugs, connective tissue disorders, malignancy, celiac disease in the esophagus, let alone the infections and inflammatory bowel disease in the various parts. So yeah, chronic inflammation in whatever part in the absence of other causes. Now, for ease of remembrance and for ease of remembering really what actually the condition is, I would like you to remember, the 3D model here. Somehow, if you read about it, everything here fits in threes in terms of the labeling, the diagnosis, the classification to do with esophageal gastrointestinal disorders. So, classified as basically according to the location, right? Eosinophilic esophagitis. I put these together because you hardly ever, see gastritis on its own, usually gastroenteritis, affection of the stomach as well as the intestines, and then the colitis as well. But, focused on this, because as I said, evidence is there, more to do with eosinophilic esophagitis, and most of the guidelines is actually extrapolated from research focused on the esophagitis. And hence, we're going to focus more on the esophagitis rather than the other localities. Now, this, to give you a prospect of time, what happened actually over evolving diagnostic approach. Such a condition, as I said, fairly recently, just over the last 20 years. But out of this, I would like just to point out a condition used to be there that if you were to diagnose eosinophilic esophagitis, you have to rule out PPI responsive esophagitis. That used to be part of the criteria. That, no, yes, try PPI for 8 weeks, go back and do the endoscopy. If the eosinophils disappeared, that is not eosinophilic esophagitis. That must be something else, reflux related, condition. So that was not included. But recently that was taken off the condition, that was removed. So basically saying, well, eosinophilic esophagitis, you can still respond to the PPI treatment. And PPI now is considered as part of the treatment of eosinophilic esophagitis. So the pediatric societies here produced guidelines in the 2014. That was actually, that was the trial of the PPI for 8 weeks. And then you go back and do the endoscopy. If it is improving, then that is if it is not improving, still high number of eosinophils, that is eosinophilic esophagitis. If it is improving with reduction in the eosinophils on histology, then that is reflux related or the PPI responsive one. That is not anymore there. So then this has been superseded by the publication of the American Gastroenterology Association, along with the Joint Task Force of Immunology and Allergy. And from there, the current guidelines has originated. So this is the reference you need to go to in managing such a condition. So what goes on? Very similar to what has been spoken about yesterday and what has been reported in atopic dermatitis and eosinophilic asthma, basically type 2 reaction, the classical way of the antigens promoting the release of the thymostromal lymphoproteins and the IL-33, activation of the T helpers, and then the release of cytokines 4 and 13, and then the 5 and the eutaxin in a very similar way. But I think what I would like you to focus on is actually compare the normal esophagus here to what goes on in terms of changes. There is a bit of difference between what goes on in asthma in particular and the esophagus. This leads to sort of changes in the epithelium as well as in the lamina propria.
You cannot share yours.
As you can see here, the inflammation leads to sort of basal hyperplasia. Normally, basal hyperplasia is just made of 1 or 2 layers of almost cubicle cells, right? And this squamous epithelium. Squamous means sort of squeezed, really, pressed on each other, with a very tight junction between the epithelial cells. And the tight junction, keeps the integrity, maintains the barrier between the lumen and the lamina propria structures. But what goes on here, specifically, see the edema in between the cells? That's a very sort of cardinal feature of esophagitis. Edema develops there, so the junction between the epithelial cells become loose. And I think this has got clinical manifestations and endoscopic features, which we see fairly often, particularly in severe cases. So basal cell hyperplasia, spongiosis, referred to as spongiosis, very similar to the eczema. Not very much similarity with what goes on in asthma. That's what you see in eczema, spongiosis as well, as a fairly typical feature of atopic dermatitis, along with the invasion of the inflammatory cells. But then here, the sort of chemotaxin of the inflammatory cells sort of activate the fibroblast and leads to collagen deposition, and then fibrosis. And the manifestation of fibrosis as a long-term complication of the condition, the narrowing, the stricture formation, the narrow lumen of the esophagus. So basically, typical type 2 reaction. In terms of diagnosing it, that is what you see in endoscopy, sort of normal appearance of the esophagus, reflected in the normal appearance of the mucosa there, while inflamed here becomes edematous, buffiness. So you lose the vascular marking. Normally you see small tiny blood vessels running through in the submucosa. You see it as blood vessels, but that disappears. See, and then leads to the development of furrowing, the longitudinal furrowing, long-term stricture formation, narrowing, and then these are the micro abscesses. That is reflected here in histology. That is the microabscesses you see on histology. That is what you see endoscopically. That is the spongiosis, the edema. Can you see the tiny lines between the epithelial cells? That is reflected clinically here or endoscopically there, along with papillae elongation there. That is the basal cell hyperplasia. So to diagnose it, you have to, look at the peak incidence of or presence of eosinophils, and by definition, you have to have more than 15 eosinophils per biofield. And that is perhaps out of all the eosinophilic conditions in the GI, that is the main evidence-based one. The esophageal one. Normally, there should be no eosinophils in the epithelium. If you see a large number, that's more than 15, that is diagnostic almost, if you exclude other possible causes. Unlike the gastritis or the gastroenteritis. So, certain figures are put in, but there's no evidence, strong evidence to actually support it. So, but 15 here is the number you referred to. So yes, that is the evidence case, but here just suggestions. 30 in the stomach, more than 50 in the duodenum, and different parts of the colon referred to as different numbers, goes up actually to more than 100 in adults. So in trying to do similarities, where do we shift to as gastroenterologists? Do we go more with asthma? We are similar to the sort of pulmonologists in accepting that it is most more similarity with the asthma, with the just the bronchial epithelium and what goes on in terms of pathology, and comparing that to the dermatitis. I personally believe that there is more similarities between esophagitis and dermatitis rather than esophagitis and eosinophilic asthma. Perhaps out of the fairly similar histology there. If you take out the keratin from the skin, you end by almost having the same structure. Accordingly, you sort of expect the same pathophysiology to go on there. And perhaps that actually goes against what was referred to before. To make it simpler, people refer to eosinophilic esophagitis as the asthma of the esophagus. I tend to explain to my patients, no, it's actually the eczema of the esophagus. I believe it's easier, make people understand it in a much better way. Eczema is something people can see. Asthma people, they don't actually see, right? People actually, even common lay people, they know how to deal with eczema and what happens and so forth, not as much as with eczema, let alone the somehow the histological or the pathophysiological similarities. So I would err more that it's more towards similarities with dermatitis rather than asthma. And as I said, the 3D pattern here is still there. The presentation of such a condition depends on where the lesions are, the location, right? And whether it is the esophagus, the stomach, intestines, or the large bowel. And another factor determines the presentation is the extent, how far of the specific organ. The whole esophagus, part of the esophagus, the D1, D3, or whatever. So that's the extent, and the depth as well. Is it just limited to the mucosa, limited to the muscles, or on the serosal side? So out of this, you can really expect the presentations. So that is a whole set of presentations. And I think what I want you to focus on is, say, mucosal involvement gives you symptoms of nausea, vomiting. If it is in the esophagus, if it is in the stomach, you develop ulcers. And very similar to IBD. Just erythema on an elevated base with a sort of denuded area, it bleeds, right? And if it is in the stomach, so outlet, gastric obstruction can happen. If it is in the intestine, and development of mucosa, again, bleeds and so forth, but also chronic diarrhea and protein loss, hypoalbuminemia and diarrhea can develop. If it is mucosal lesions, if it goes deeper into the muscles, making a mass, it may obstructive symptoms, right? If it is on the serosal side, as you can imagine, the inflammation goes, the features of it, into the peritoneum. Ascites develop, right? And abdominal pain. Right, so in comparing features, because of the short history of the case, in children you see more of symptoms suggestive of mucosal involvement. Abdominal pain, nausea, vomiting, feeding difficulties, just do not want to feed. And then of course, that leads to failure to thrive and fluttering of growth. All the children, they may come with sort of difficulty swallowing as well. Here, more of the dysphagia, food impaction, chest pain, and heart pain in adults. And if you were to compare, the presentation features, this is for adults, the gray one for children. As you can see, significant difference in the dysphagia score, less among kids, food impaction less, but see the vomiting, abdominal pain, regurgitation more with the kids. That is reflected in a very similar way in the endoscopic features, sort of more of the inflammatory changes among children, more of fibrotic changes among adults. So as you get older, as the time goes on, you develop more chances of presenting with esophageal stricture, see more in adults, less in kids, food impaction reflected of that, dysphagia, more of the non-specific symptoms among younger children. Now, this is an interesting fact referring to the delay in diagnosis. The longer the delay was, the more likely is to present with fibrotic features over time. As you can see, as time goes on, you get more and more of fibrotic features, and this reflects in the presentation of food impaction and stricture formation. So early diagnosis and starting treatment is really important, and that is summarized here recently in one of the pediatric journals. If you suspect eosinophilic esophagitis based on these symptoms, you undertake upper GI endoscopy in such a child or an adult aiming to take biopsies. The diagnosis is histological. Then if you find more than 15 per high power field, then that is eosinophilic esophagitis, as long as other secondary causes is excluded. And that is what you see again, just edema following there. See the concentric rings and the longitudinal furrowing. That's exactly what you see. And that is then the establishment of high number of eosinophils. And at the same time, don't forget to take biopsies from the other parts of the upper GI tract, because it cannot be just limited to the esophagus. You may get involvement of the duodenum as well as the stomach. So considering that you rule out other causes, then that confirms the diagnosis. And that is a real case. Just actually a few weeks ago, one of my patients, they see the typical changes there, the concentric rings, and the spongiosis I was telling you about. See the abscesses here. It makes the epithelium very friable. You touch it, it opens up, splits very easily. That tight junction between the epithelial goes away, and that is really just on entering the esophagus without actually really having a good look, damages the mucosa. See the muscularis mucosa there, really all along the full thickness of the esophagus. Nothing happens, recovers fairly quickly. And if you you see sort of an actual narrowing of the lumen, you dilate them. This is actually through the balloon view of dilatation. You will end by developing sort of some damage to the mucosa. That is expected to be the case after balloon dilatation. How much of the other supportive diagnostic tests play a role in such diagnosis? Very minimal, really. There is no specific biological markers to diagnose eosinophilic esophagitis. It's histological. Unlike what you were talking about in terms of asthma, the nitrous oxide, and the other biological markers. So, yeah, the aim of the treatment here is actually to achieve full, deep healing, not just clinical improvement, not just endoscopic improvement. It's actually histological improvement. That is, you go back, you take a biopsy, there is no increased number of eosinophils. And this will certainly be associated with improvement in symptoms and the different endoscopic scores. So, yeah, that is what people are doing nowadays is based on the recommendation of the American Gastroenterology Association and the task force of the Immunology and Allergy. That is the current advice, which is summarized here recently by what you can see. You diagnosed it, then you've got two options. You go for medical treatment or dietary treatment, and sometimes you need esophageal dilatation. But what is offered first? Personal choice between you as a physician and the patient. There's no hard rules. And I think what actually being decided for North American or European may not really work, and you have to take that into account. As a personalized kind of agreement between you and the patient. But that actually opens confusion, to be honest. Do you go with this? Do you go with that? What actually agrees with you may not actually agree with the others. It is indeed really very, very confusing. But you have to sit with the patient and you have to give them the option, because you will not achieve good compliance unless it is agreed, unless the social circumstances is taken into account. So again, here the 3D pattern plays a role. In terms of treatment, it's the 3D. You either go with drugs or with diet or with dilatation if you think it is necessary. And out of the drugs, basically corticosteroids and proton pump inhibitors. There are some other medications there that's possible. Diet, again, 3Ds, sort of, it's either you go for empiric elimination, the 6 food element, or you go for based on allergy test results, right? Or you go to elemental diet. Everything is broken down to its basic elements. Dilatation, different ways of doing it. Now, this is the pros and cons of the diet. You go with the elemental. I don't know whether you have tasted elemental food, really. It's basically amino acid based, or it has improved recently to be sort of semi-elemental or polymeric. But basically, it's very similar to you eat some food, get digested, you bring it out, you bring it out again, and you re-swallow it. It tastes horrible. It smells very, very, very bad, and it is exclusive. No other food. Patient starts to crave for other options. Expensive as well. Not sort of covered by all different kind of insurance. That's the elemental one. The empiric, this is the most commonly used, but based on no actual evidence whether it will work with the patient or not. 6 food diet, 6 food exclusion. The most common allergens: milk, egg, wheat, soya, nuts, and seafood. Just avoid them. But this is not easy. For long term, you're dealing with kids and adolescents. It can be effective. Elemental is more effective there. The other options is based on food allergy tests. How sensitive, how specific the food allergy test. We I think argued this quite a lot over the last 2 days, and accordingly, it's not as successful. To make it easier, now instead of the six food elements, people are talking about 2 main things. The step-up approach. You start with 2, go to 4, and then to 6. If it doesn't work here, go to 4. If it doesn't work here, go to 6 food elements. But the regulations is, even with that, you have to assess response. You put them on a selected choice, you endoscope them, and then you challenge them. very tedious, very demanding process, really. Okay, so in terms of the PPIs, I think the thing to know is for example, the omeprazole or the pantoprazole and so forth. It's helpful in eosinophilic esophagitis, not because of its anti-secretory medication, not because it reduces acid production. It has got anti-inflammatory effect through the downregulation of the eotoxin, right? And out of that, it promotes the tight junction between the epithelial cells, and it improves the barrier function of the epithelium. So yeah, it's proven beyond doubt. It's useful in about 50 to 60% of cases, and in inducing as well as maintaining, as proven histologically and on clinical basis. Big study, meta-analysis, sort of almost 600 patients, kids and adults. Overall histological improvement 50%, overall improvement in the clinical 60%. Budesonide, yeah, perhaps it's better effective in sort of, this is 6 weeks, comparing budesonide to placebo, sort of 60% almost improvement in clinical histological. Similar thing, the clinical remission, histological remission is higher. So histological remission does not really go head and head with clinical remission, and that is the case with endoscopic remission as well. Sort of long-term, 48 weeks, similar results, but the important fact here, smaller dose is as effective as higher dose. 0.5 milligram twice daily or 1 milligram twice daily, no difference. So basically saying you induce with a higher dose and you maintain with smaller dose of budesonide. Yeah, would you go with nebulized? Because we've got two options. We use the inhalers or the nebulizer solution, and we ask the patient to actually, don't inhale them, swallow them. Or you give them the oral preparation, which dissolves in the mouth and slowly passes on the esophagus, maintaining contact for 15-20 minutes. So we say, do that. Do not eat or drink for half an hour. The evidence is there that in favor of the oral one. See the nebulized one, there's no difference before and after. The oral based one, so whether it was viscous preparation, we actually take the nebulizer solution, mix it with honey, mix it, and then ask the child to swallow it. So there is a significant difference there, proven, by sort of technetium scans here. See, this is the oral one. See the contact with the esophagus, while the inhaled one goes mainly into the lungs. So out of this, the AGA and the Joint Task Force were able to come with these recommendations, although the evidence is not very strong, but they promote proton pump inhibitors. They promote topical corticoids, topical corticoids in comparison to the oral. Oral tablets, oral intake is not advised. Elemental diet, or used through the empiric 6-food elimination and allergy testing if possible. But this is conditioned here. If the patient does not like, if the patient does not agree with it, if the circumstances does not fit, the patient has got the option not to go for that. So yeah, I think then go into the biologics. I think there are enough reasons to actually think about the biologics. Perhaps the simplest or the simplest, that such patients are not just suffering from gastroenteritis or esophagitis. They may well have A to B, they may well have asthma. So you give one medicine, treats all, let alone the complications and the difficulties of dealing with oral medications and the duration of the treatment. You take it every day, or you take it once every 2 weeks. So out of that comes up the trials of using biologics. This is again out of the recommendation of the AGA, that anti-IgE, this is actually the only one where it advises against the use of the anti-IgE. There's no evidence, there is evidence of it's not useful. While anti-IL-5, IL-13, and the other common or the other less effective medications under clinical trials only. They're not recommended on a scientific basis. If you want to try them, really basically try it. So tobellimab, after the publication of the AGA, more evidence came to light of its effectiveness in treating eosinophilic esophagitis. Here, published phase 2, sort of there is an absolute change in the symptom score, comparing the placebo to tobellimab, as well as the esophageal eosinophilic number. That is the case, comparing histology as well as endoscopic findings in favor of tobellimab. And here the histology, as well as in terms of the extent and the depth of eosinophilic infiltration. So there is more evidence coming through, recently published in one of the conferences, that even actually a long term at week 52, those who were put into the placebo group was switched over to take the tobellimab, and their symptom score improved to almost the original one in all the different parameters. It is found to be safe, minimal side effects. There are a lot of, some other studies still going on. Sandecimab as well. I think there is some evidence being published, along with other whole host of biologics. Okay, so eosinophilic gastritis. Just briefly wanted to show you sort of the ulcers which can develop, the erythema patches, and the polyps as well. So you see polyps, not just in the respiratory, but also in the GI tract. Now, this is a child who came to see us when he was 11, with 5 years history of abdominal pain, vomiting, and bilious vomiting. But he had low albumin, raised amylase lipase, and high eosinophilia. Okay, this is the upper GI contrast study showing contrast stopped at the duodenum with complete blockage. Cannot really go beyond the second part of duodenum. Ultrasound scan showed that dilated duodenum, obstruction there with thickening of the duodenal wall, along with dilated intra and extrahepatic biliary tree. CT confirmed the same findings. We did an endoscopy. The mucosa looked normal, no changes endoscopically, as well as no changes. This is the endoscopic appearance of the child. The duodenum is completely blocked. Did not even allow the 5mm scope to pass through. Histology of the mucosa is normal. Then we went on to do full thickness biopsy, and that is what it showed. Dense inflammatory infiltrate, eosinophilic in the muscles. Treated with IV steroids, maintained on oral steroids afterwards. 2 months later, complete resolution of the obstruction. So, evidence of reduction in the eosinophilic count following steroids and clarithromycin as well. This patient here, if you look at his numbers, these are relapses, these are remissions. It goes down to almost normal. For years, he was treated with so many different things, you name it. For about 6 or 8 years, everything was seen everywhere, overseas and here. No improvement on discussing his case, taking the similarity with asthma and dermatitis. Because why don't we try anti-IL-5? And we started him on mepolizumab, and since then, for about 1.5 years, remained in remission. No evidence, we could not find any previous published literature to support this, but it seems to have worked. Instead of 3 to 4 times admissions per year into the hospital with obstruction, he has remained over the last 18 months symptom-free. A lot more questions to answer, but I would like to finish by really raising alarm that you guys, you may run out of business if we
Take your time.
yeah.
1 minute.
So yeah, well, finishing. That if this to materialize, you know, the risk that we may actually treat all these chronic inflammatory conditions by fecal transplantation, right? And this may really alter the basic problem there, which, you know, you alluded to yesterday, that the type 2 reaction was, you know, meant to deal with a sort of intercurrent, helminthes and so forth. We believe on the gastrointestinal side that having a healthy gut microbiome is really essential in the maintenance or actually in getting rid of the inflammatory conditions, whether it is asthma, eczema, autoimmune diseases, rheumatoid disease, and so forth. So there is a rising alarm that we may even treat asthma with fecal transplantation. We may even treat atopic dermatitis with fecal transplantation, and the fear that might actually take you out of business. Thank you.
Thank you, Doctor. Thank you, Dr. Amer.